Good morning, everyone. First of all, welcome to the Health and Wellbeing Board, 25th of July. Can we elect a vice chair? Denise, could you nominate vice chair, please?
Well, I wanted to nominate myself.
Okay, thank you very much. Seconded. I also nominate Neil for vice chair as well. Second vice chair. Thank you very much. Appreciate it. Right.
Did you know that was going to happen?
First of all, welcome everyone to this meeting. Just to let you know that this meeting is being recorded and will be uploaded to the Council's YouTube channel. Can I ask everyone to ensure you use your microphone when addressing the board and ensure it is turned on and off after you on when you're talking and off when you complete your statement. First of all, item 2, apologies for absence.
Chair, Councillor Cousins, Michael Bell, Sally Dehan, Andy Trotter, and I believe the lateness.
Thank you very much. Are there any other apologies? No, thank you very much. Item 3, there's no urgent business. Item 4, do any members have any declarations or any declarations to declare? I see none. We'll move on. Item 5, is everyone happy to confirm that the minutes are an accurate record of the meeting held on the 8th of December 2022? Brilliant. Thank you very much. And we'll move on to item 6, the ICS strategy. And this is to note the South East London Integrated Care System's 5 strategic priorities and to agree to implement them through the health and wellbeing strategy aligned to our Greenwich plan. And we'll hand over to Neil, who will be presenting. Thank you.
Yeah, is it up? It's not that one. Did you send it to Daniel? I did. It's in the pack, and I'm happy to talk to it because I wasn't going to go through it in detail because I think it's more covered when we come on to the health and wellbeing strategy. So I suggest. Okay. So, yeah, thanks very much to everyone. Back in December, we talked about the kind of alignment of all the strategic priorities, and we'll talk a bit more about that in the next item. But this is just to kind of formally confirm that the integrated care system have set out 5 strategic priorities.
Thank you, Neil. Can you just move your mic closer to you, just for the sake of hearing it? Just bring it. Yeah, thank you.
Thank you. So the South East London Integrated Care System, which is made up of all of the 6 local authorities, the 5 main NHS providers, and the Integrated Care Board, who I work for, all together make up the Integrated Care System. And the partnership basically signed off these 5 strategic priorities. We knew them in rough draft when we met in December, and they have now been formally ratified into our Integrated Care System strategy, and we've incorporated those 5 into our health and wellbeing strategy, which we'll come on to. But just to highlight what those 5 priorities are, the first is prevention and wellbeing. So that's improving prevention of ill health and wellbeing for people in South East London to stay healthy and well. Second one is early years, so making sure that children get a good start in life and that there's effective support for mothers, babies and families before birth and in the early years of life. The third one is children and young people's mental health and improving children and young people's mental health, making sure they have quick access to effective support for common mental health challenges. The fourth one is around adult mental health, making sure adults have quick access to early support, prevent mental health challenges from worsening. And fifthly, around primary care and people with long-term conditions, making sure people have convenient access to high-quality primary care and supporting support and care for people with long-term conditions. So those 5 strategic priorities are now agreed. The good news is we've been able to incorporate those into our health and wellbeing strategy. What does it mean to be a priority? And I guess that's something that's probably useful to know. The best way to explain it, because there are many things that sometimes we have to do, like winter will come and we have to respond to that. But these 5 priorities saying, if it's about allocation of resources, we will put more resources into these areas to tackle these things. What's great about them is they're all in that preventative space. It's not, we spend most of our money in the expensive end of the system for people where things haven't gone well, and people are in long-term placements, or in mental health hospitals, or in acute hospitals, specialist services. But what this strategy says is where we want to put our resource and our priorities is upstream in that prevention space, and supporting people early on in that process. And obviously 2 of the 5, specifically being around children, is you need to start early in life. So I think it's a great overall umbrella to work with. And what then the rest of my paper highlights is, off the back of that, we had then developed something called a 5-year forward view, which was a set of plans of what we want to do over the next 5 years. And there's quite a lengthy document over almost 300 pages long, which captures what each borough in South East London is planning to do, as well as what some of those common threads are across. And I'm pleased to say we've been working hard to make sure that our health and care plan, which is now our health and wellbeing strategy, subject to our approval later on in this agenda, basically make sure that all of that is joined up together. So there was quite a bit of engagement that happened with this, and I've summarised the link into that, but I wasn't going to go into the detail of that. So I wasn't going to go through the detail of the document, but I am more than happy to answer any questions that anyone has here today.
Thank you very much, Neil. And obviously, not the first time that we've seen this document, and it's obviously come to this board before when it was in its draft form, but obviously it's great to have it here now that it's been ratified and agreed by all partners. So thanks for your presentation. We'll move to questions now. Joy, I see you have your hand up, so I'll bring you in first.
Thanks, Neil. Joy, Healthwatch Greenwich. I'm interested in absolutely the focus on prevention, early years, wellbeing, to try and keep people healthier for longer and try and reduce the need for more acute settings later on in life. And I suppose I wondered, given that we know that our local trust is going to increase the number of beds by 100 over the next few years, that sort of sounds a little bit sort of counterintuitive. Surely this is about reducing the need for those acute settings and perhaps reducing the number of beds, but they're going in the other direction. They're increasing the number of beds over the next few years.
Okay. So do you want me to take each question individually? So, yeah, thank you, Joy, for your question. I kind of would agree with you in the concept. So what we need to make sure is it's not just about growing and putting all of our resources into the hospital. I think what's specifically known at the Queen Elizabeth Hospital is when the Queen Mary's Hospital moved from being a kind of a fully functioning acute hospital into one that basically does planned care procedures and has an urgent care centre there, that basically the demand on the Queen Elizabeth Hospital is very significant. So what we need to do with the overall kind of number of people who are waiting for long-term for operations, for surgery, what often happens with the hospital is you get the acute demand that comes in that requires people to be admitted. Then that means that people who've got a planned procedure, be it for cancer treatment or for hip or knee replacement or whatever, they get bumped basically because there isn't enough space. So what we need to do is make sure that in order to tackle the elective waiting list, and that's known as a national issue, so we just need to get the right balance in the system overall. We're not looking at expanding the physical hospital site. Some of this is about reconfiguring the way the hospital site works. But the overall emphasis, this is about creating the space, not necessarily massively growing the workforce there so that they can become a more efficient site. At the moment, they often run, I was director of winter there for a previous winter, they often run at like 110% capacity. And you might say, well, how on earth can you run 110%? Because surely you can't ever be over 100%. But they have various escalation areas. But these are areas that should be used for like day case procedures and things like that. But then basically when you don't have enough beds, then people go into those areas to be used. So what they really want to try and do is make sure that the space for those day case kind of procedures is protected, and you basically want to run a hospital about 95% full, because then you can be much more efficient and it's better for sort of safe patient care. So all of those factors together, the demographic growth in Greenwich is also quite significant, and we've also obviously got some demographic growth into Bexley as well, which is the main catchment that goes in. So I think the plan on that is to do that. But the funding arrangements, just the medium-term financial strategy that's been agreed for the ICS, basically puts significant additional funding into all of the areas that I've highlighted in these priorities. And I guess the challenge on prevention is about timing. You prevent something today in terms of you're going to improve someone's physical activity or their diet. That's not necessarily going to have an immediate impact on their need to go into hospital. That's going to take time. And so it's basically we've got to do both of those things together, but it's about shifting our approach overall.
Thank you very much. Now I'll take questions in threes. Florence, Rachel, and Sarah.
Thank you, Chair. I'm really pleased to see that the prevention work and focus and the stronger focus on children and young people is running through the plan, which is great. It's not a question, just a reflection that the Children and Young People's Plan is in development now, will be ready for April 2024. I've been really clear with the team, and I think in Children and Young People's Partnership as well, that we won't replicate anything that's in the plan. We'll reference things that are in this plan, but we won't have any priorities. And I actually want the new Children and Young People's Plan to be much more the voice of children and much more a new look and a completely different type of plan than having another plan that sits alongside. So just wanted to kind of be clear about that in this meeting. Great to see it in the health and wellbeing document, and we won't have duplication of priorities across the whole range of different plans that we have.
Thank you, Councillor Kerike. Other than the sort of theme of prevention is better than cure running through these priorities, what other criteria set these ones aside as being our top priorities, and which ones, what other areas didn't quite make it?
So I think it's about the tackling inequalities. So I guess that whole emphasis on the prevention is wrapped around that. It's the overall kind of golden thread about needing to tackle inequalities, which obviously were in particular highlighted through the COVID experience, but have been there for a while. And that's where we need to put that additional effort. I think the other kind of priorities you could argue, you know, if you look at the national kind of media would be saying, you know, how many people are waiting in A&E or how many people are waiting for operations. The focus could be just about the treatment end, and I think it was a real clear choice to say, no, we need to focus on that prevention end. And particularly it's about recognising, and this is a health and wellbeing board, that 80% of all the determinants of health are the things that the rest of the system does in terms of employment, education, having great schools, the community that we have. And if we just put our focus on how the NHS providers, for example, get more resources to do things, then we actually miss the trick about actually saying how do we work more effectively with our partners. So I think it was a very clear decision. This is about the integrated care system, about how we need to work together. Each of those providers will have their own national targets given to them that they'll have to focus on. But for us as a system, we want to be in that prevention space, and they were the active decisions that we made.
Sarah?
Yeah, I mean, mine was more a comment, really, just to add to what Neil has said. So there was quite a long process, Rachel, that was gone through in terms of sifting out the priorities. And as Neil said, driven very much by health inequalities and how do we make that shift to prevention and how to make a commitment to that by shifting some of the money. Just to come back on Joy's question, absolutely understand the logic of that. These are about the priorities and how we make that shift across South East London and across the whole system. But as Neil set out, the occupancy at Queen Elizabeth Hospital, for example, is much higher than at some of the other hospitals within South East London. And what that then has an impact on how people are discharged and the effectiveness of all of that. So it's really important that we've got sufficient capacity given the growing population, etc., as well as making that shift to prevention. And you know, the numbers of beds per head of population, again, is lower than you would see in inner South East London. So just important to recognise that.
Thank you very much. Steve and then Naomi.
Thank you. I just wanted to make a comment about the relationship between what we do, and we've got our health and wellbeing strategy coming up next on the agenda, what we do locally in the borough and what happens once across South East London, because I think one of the things that we'll need to kind of work with as the years go by is getting that right, so that we've got, you know, the things that make sense to do across a bigger footprint happening through South East London, and the things that are best done locally, organised here. But having said that, I'm involved in some of the prevention work that's already happening, and as Neil said, there's money behind these priorities. There's £4 million that have been identified for some of the prevention priorities by South East London at ICB. I co-chair a smoking group, a tobacco group that works across South East London, and we've already been able to access some of that funding to support, for example, significant investment in stop smoking services within all of our NHS trusts in South East London, including Lewisham and Greenwich and Oxley's trusts. And we're negotiating around some additional elements of that funding for other tobacco-related work to make sure that we have a really good offer going forward for smokers who want help to quit. So I think that there's already kind of evidence of that money sort of flowing both across the patch, but also into sort of local trusts and borough level activity. I know that's true for a number of other areas as well.
Thank you very much, Naomi.
These priorities are fantastic, and I've got absolutely no issue with them. It's just I can see that in the future, as you know, as medical science becomes more and more effective, there are going to be more and more treatments that cost a lot of money, because they always cost a lot at first. And these priorities are relatively low cost, and those treatments are relatively high cost. How do we make sure that these priorities continue to be a priority when other things appear that actually we need to do to support people who we may have prevented initially from becoming ill, but they've become very ill, and then they need a huge amount of investment to support them with whatever condition they have?
Yeah, thanks, Naomi. It's a really good question. Fortunately, in a way, it's not quite a lot of these things in terms of new treatments are determined at a national level. So the National Institute for Clinical Excellence, basically, or effectiveness, looks at all of the new drugs that are coming in, the new treatments, and recommends whether they're adopted or not. So very often there are new exciting things that can be done, and sometimes they do come with a high cost. I think one of the advantages of working in South East London with organisations such as Guy's and Tommy's and King's, which are kind of quite leading in research, is they quite often will have separate fund streams to support that. So you get pilots and innovation, which mean you get far better outcomes. I remember people, some statistics was like only 2 or 3% of people would survive testicular cancer. This was about 25, 30 years ago, and now the stats are absolutely the opposite end. It's now 98% survival rate, and that's because of the kind of the trials that have happened. So obviously we want there to be that innovation, but that there can be a concern that comes at a cost. I guess the focus of the Integrated Care Board and the Integrated Care System and the budgets is to focus to say these are our key priorities. And so what's often happened each year for the hospitals is they've actually had a fixed allocation, and it's not been a very large allocation growth in comparison. So they've had to make internal efficiency savings. And that's a real challenge, because they would like to have far more resource, but we've actually said no, we need to grow our community services, we need to grow what happens in community care. So there's a massive investment in additional roles in our GP practices at the moment. We've now got over 30 pharmacists working in GP practices supporting them. So there's a whole range of initiatives, and I guess that national policy is what helps us, but also these 5 principles and priorities give us some guiding points. One of the things, excitingly, we've also committed to is, despite the financial pressures, they've actually allocated specific funding for health inequalities. and they've committed that that funding each year will grow as well, being allocated to each borough. That's hard because the money isn't really there. They're having to say to other parts of the system, no, you're going to have to cut in order to make sure we can move into this area. So I think we're starting to see the evidence that these things are being followed through, and I just commend that. We just need to make sure we hold them to account. I guess that's part of, I mean, Anthony, as the Health and Wellbeing Board Chair, sits on the Integrated Care Partnership, can be saying, what are we doing against this, and making sure that we follow it through. And I know I've had conversations with Councillor Morrow about finance for mental health for children, and that's something that we've made sure that we're putting that additional resource in, and that's part of our medium-term financial strategy.
Yeah, it's funny because I was just about to mention the question of accountability, and then you mentioned me. But obviously accountability, I add to that, this Health and Wellbeing Board adds to it, and all that sit on the ICS and ICB add to it. But in terms of accountability to the strategy, obviously you've got strategy in place at the moment. The next question is how you demonstrate accountability, not just through the panels, but how you articulate it and showing that you're delivering on outcomes. That's number one. And number two, just a question that Naomi asked even more, where we are seeking to challenge and move things on and accomplish the priorities as set out in the strategy. How do you envision using the voluntary sector and community groups to help fulfill the outcomes that you have set? And is there a plan that you have in place to kind of help that? Because obviously, part of this is about taking support and interventions to where people are, and not necessarily thinking of ourselves as institutions and requiring everyone to come to us. So how as partners, should I say, that all have that kind of responsibility, how do you see that whole working? Thank you.
It's more just bouncing off your, because this is talking about a huge cultural shift throughout the whole organisation. And I'm just minded of page 47 where it's talking about how we plan to allocate our resources. And I know you start to touch on some of that. So how can you, I suppose, what have you got in place, or how are you going to monitor in? Or I know at the strategic level, we'll be asking that question, but how do we just sort of guarantee or get reassurance that that cultural shift will continue in the right direction?
Thank you. And then we'll go to Councillor Taggart-Ryan for her question as well, and then you can come in now. I know those were chunky ones.
Forgive me if this is, you don't have this information to hand, but I would just like to kind of get a ballpark idea of the outcomes per investment in these. So do you have an idea of X% spent on early years or relating X months of savings or X a number of non-admissions that would have occurred? How are you forecasting? I wouldn't say implementing, because this is obviously over decades, but how are you forecasting the outcomes for this?
Okay, thank you. Really, really good questions. And part of me wants to say, can we pause the answer to those until we do the health and wellbeing strategy? Because the way we've developed the health and wellbeing strategy is saying, yes, these are the ICS priorities, but we've actually incorporated these with our Greenwich, the strategic priorities from the corporate plan from the council, and incorporate those together to create our health and wellbeing strategy. So that is how we're going to do the VCSE piece of work, the local engagement, and making sure this is real. And then, so I kind of want to kind of unpack it more under that item, because that is, we've actually made this ours and localised it. And there is, but just to answer the VCSE point at a South East London level, we've got a dedicated role, a lady called Tal, who is working across the VCSE sector across South East London, say, how do we create a shift across all of those areas? And we're doing, so a number of our VCSE organisations have been part of those workshops and conversations. So there's a definite real commitment to do that. What I would say is we've got a great community and voluntary sector in the borough, and there's an awful lot more we can and are doing in that area, and their strengths are critical. But the way we're actually going to do that is through kind of our local delivery, and we can unpack the specifics of that.
Thank you. And it's a really important point because I'm going to bring Sarah in and then go to Naomi, especially because obviously having a strategy then thinks about how we commission. And obviously commissioning is key to be able to bring in services that help deliver on your outcomes. And obviously when it comes to commissioning, we always need to be reflective of making sure that we're commissioning the right things to help us, but also commissioning things that have an impact. Sarah?
Yeah, so just to add to what Neil said, so Tal's been doing some brilliant work thinking about what the relationship should be with the voluntary and community sector at the ICS level, and there is a paper that she is bringing to the Integrated Care Partnership, which I think is due fairly shortly. I guess the other thing will come on to the engagement and working locally, but I'm also conscious that the South East London level do quite a lot of engagement across different boroughs that cut across sometimes one borough, sometimes 2, 3, 4 boroughs, so it might be something we want to consider as a board, actually having visibility of that work, just to know at this board that work's going on. So it is reported on a monthly basis on the ICS website, but we might want to think of a way of bringing it into formally just reporting here what's been happening, because it's hard to keep up with it all sometimes.
Thank you. I think that's really helpful. Naomi, I guess the question to you is, how are you finding
Yeah,
the process
I almost
engaging?
don't want to cut across the fact that we're going to do the health and wellbeing strategy, and rather than me saying the same thing twice, maybe waiting until the health and wellbeing strategy discussions, because it is more about the local stuff, isn't it? Yeah.
And just in terms of your engagement with ICS, how have you particularly found it, especially in relation to the voluntary sector?
So yeah, Tal's fantastic.
Yep.
Unfortunately for me, there are a lot of meetings that sometimes I can't go to, but the way the engagement's happening across South East London is where organisations work across borough. They're more engaged with the Alliance than organisations that are one borough only. So, but the work has been very much about understanding that at a local level, most groups are pretty widgy. And therefore, if they are very small, the way you commission has to be very different than if you're, say, commissioning Age UK or something like that. Yeah.
No, I think that's a really relevant point, and probably one that we should pick up at the board in terms of acting at a sub-regional level and translating that to very grassroots, local, super localized level. I'm going to bring Matt in, who will be my final question. Matt?
Hi, so I think we might get onto this in a bit more detail under the health and wellbeing strategy, but I very much agree with what's been written here, but I'm not clear how it's going to be put into practice. So will there be further, more detailed reports that include spending and activities to follow up on this?
Yeah, in simple answer, yes, and I think that will help answer Rachel's question as well around, what do we need to, where is the spend against the different outcomes? We can provide that from a South East London perspective, but I think what will be much more pertinent is what's it actually mean for us as a borough. So I have from the NHS budget, I have responsibility for about £160 million, but there's also the way we're approaching this work is about in shared ownership. So we've got our integrated commissioning directors, so it's about bringing that collective resources together with the resources of our other organisations to make this stuff happen. So I think that's the best way to do it when we come onto the health and wellbeing sort of strategy, the next item.
Thank you very much. Denise, for comment?
It's not comment, just information. So the IPC had a meeting yesterday, and Tal presented her draft document of the voluntary sector charter. I think that's what it was called, which led to a very lively discussion. So, so it was very, very interesting from all the different boroughs that were there in the room, and as well as the voluntary sector that were there in the room. So I know it's not a completed document yet, and it's doing its rounds. I don't know if that's useful to members.
No, that is very useful. Thank you. Right, well, now move on to the next item, which will be the Greenwich Health and Wellbeing Strategy 2023 to 2028, and we will hand over to Steve Whiteman to present. Thank you, Steve.
Thank you, Chair. We're just going to get a presentation up, just a short presentation to take us through the highlights. Neil and I are going to do a double act on this. And the first thing we're going to do is just to show you a snippet from a video, which Daniel is queuing up for me. So, yeah. Oh, yeah, that's not the right presentation, and that's why we're not going to show a video, because I'm confused by the presentation that's up on the screen. That comes later on another item. Apologies. It's the Health and Wellbeing Strategy presentation, Daniel. Thank you, Neil. It's been one of those mornings. I got up at 4 o'clock. That's it. Yeah. Great. Next slide, please. So, as board members may be aware, the Health and Wellbeing Board has some statutory functions. One of those is to develop and publish a joint local health and wellbeing strategy, and the joint is between the local authority and the NHS, but obviously our Health and Wellbeing Board has other partners around the table as well. So just to remind colleagues that our previous strategy was developed and agreed by the then board in 2019, so not long before the pandemic hit. So its implementation has been significantly impacted by the fact that period of time occurred. However, I think a lot of the priorities that were in the strategy, and that there were only 4 main areas of priority actually, were things that we did need to both pay attention to and also learn more about during that pandemic period. So the priorities in the previous strategy were further developing our prevention system, so expanding our Live Well infrastructure, developing a more thoroughgoing, systematic prevention offer in the borough, addressing healthy weight, and in particular around diet and physical activity, a focus on mental health and well-being, and looking at the further development of the health and care system to be more outcome focused and more joined up and integrated. So all sort of fairly familiar themes. So after the pandemic, this board decided that although we were still in date with the current health and wellbeing strategy, it made sense to refresh the strategy to learn the lessons from the pandemic, and to make sure that those lessons were reflected in the priorities, but also so that we could ensure that we had strong alignment with some of the new strategic context. So the Greenwich corporate plan with its mission 1 around the health priorities, and also the new NHS strategies, which Neil's just talked us through in terms of the establishment of the ICBs and the need for them to develop their own plans. So what we've tried to do is to pull these things together so that they're all describing the same story and they're all focused on the same set of priorities. We've also reviewed our intelligence in terms of our understanding of the greatest causes of mental and physical health in our population. I'm going to come on to a little bit more on that in a second. And also building on our understandings of the things that matter most to our residents. So again, we've obviously had the consultation process that led to the development of the Greenwich plan, where residents told us what mattered to them. Similarly, the ICB strategy has been developed with a significant amount of engagement with our communities, and as Sarah says, that's an ongoing sort of iterative process. Next slide. So some of the key themes within our strategy. In the wake of COVID-19 and the impact that this has had on our population, It really redoubles our focus on inequalities, on tackling racism, discrimination, the social, economic and health inequalities which continue to blight our communities. It recognises on a more sort of positive footing the value of our neighbourhoods, the assets that we have as a borough, and in the communities that we have in supporting better health. So really good sort of a lot to build on. And we've talked about the community and voluntary sector as an example of the assets that we have already in place. Obviously the importance of mental and physical good health and the need to work together to support children and families, to give children and young people the best start in life is a key theme. We also particularly acknowledge that we can't achieve our vision of a fairer, healthier Greenwich without collaborating, and that communities should be at the heart of that collaboration. So I think signalling more of a partnership with our communities, with our populations, not just with the organisations that are there to serve them. Next slide. So this might be a little bit tricky to see, but in the strategy we use this infographic to describe what we know about the most significant causes of death and ill health in our population. On the left-hand side, it shows the biggest causes of mortality. So Neil was mentioning cancer survival rates earlier on. That's a really good news story, but cancer is still the biggest cause of death in our population at 30.9%. And a significant proportion of that is potentially preventable through better prevention and earlier detection and treatment. Heart disease and lung conditions follow on as the second and third biggest numbers there. Again, significant opportunities for prevention in both of those areas. On the right-hand side, you've got morbidity. So a different group of conditions come to the top of the tree when we're looking at the things that impact people's quality of life and their health during the life course. Musculoskeletal conditions, so joints and back pain, neck pain, etc., are actually the biggest cause of impact on quality of life in terms of numbers, followed by mental health conditions. So the things that might have an impact on our quality of life being somewhat different from those that might end our life. Next slide. And then this slide just gives an example of some of the inequalities that we know we've got in our population. One being the difference in life expectancy on average between men and women, where women live 3.5 years on average longer lives than men. And then you can see the healthy life expectancy, so the proportion of that life lived in good health without significant illness or disability, where men live both shorter lives but also have a shorter proportion of their lives lived in good health, with on average healthy life expectancy only being 60 for men in the borough, which is, as you know, 7 years below retirement age. So also an economic impact as well as a sort of personal impact for the people concerned. Next slide. I think this is you, Neil.
Yeah, thank you. We're going to do a bit of a double act on this. So basically, just really picks up on the previous presentation. So what we've said is that our new health and wellbeing strategy really is about building on the lessons from that pandemic and incorporating the missions from the Our Greenwich plan relating to health and wellbeing, which is particularly mission 1, and that this also then becomes our local health and care plan for Greenwich. So if you're a member of staff currently working in the Royal Borough of Greenwich area, whether you're in health or care, you will only have one set of priorities, one set of plans. Prior to this agreement, you would end up having maybe 6 plans that all say some of the same sort of language, but in different words, in different plans that don't align with different dates. So the idea of this is that if you're a member of staff, and therefore if you end up being a resident at the end of these plans, it's joined up and it makes sense. And this is the fruit of having that integrated commissioning stroke planning leadership approach that we've had. So if we go on to the next slide. So in terms of the Greenwich aspect of this, we've got people's health supports them to live, supports them in living their best life. So that is absolutely key to make sure that the borough's priorities, and obviously there's been the whole democratic accountability work and the engagement that happens around Greenwich, that people won't experience discrimination, and the strategy that we've got includes a real priority about tackling those unjust inequalities or inequities in health outcomes and ensuring equitable access to health and care services, and then children and young people reach their full potential, an absolute echo of that Greenwich plan. So on the next slide, I've just gone through the South East London ICB strategy. I could have done a test and kept that blank and asked you to say what the 5 priorities are, but those 5 priorities are incorporated. So when we end up, we go on to the next slide, you will see essentially there's an overall strap line of Live Well Greenwich, but essentially 5 kind of easy to remember phrases of starting well, being well, feeling well, staying well, and age well. And within there's 10 kind of key priorities. So we've incorporated the 5 from the strategic priorities from the integrated care system, with Start Well, around children and young people getting the best start to life. In terms of being well, about everyone being more active, and everyone can access nutritious food. If we don't get that bit right, it is such a critical component. And when we come on to the next item, which is on the public health report, you'll see the real priority around that physical activity side of things. Then feeling well, which is part of the priority in the borough. We've separated the adult and the children's mental health there, but also recognising that we need to reduce the number of people who have a poor health outcome as a result of addiction or dependency. So that's smoking, alcohol and other substance misuses. And then staying well. So really key important areas around everyone having access to services they need on an equitable footing. That is particularly recognising that coming out of the pandemic, we know we've got waits, we've got delays in the system, and we need to try and get to that place where there is equitable access everywhere. So there's a number of things we need to do there. The next one, and I think this really builds on the point about the role of the community and voluntary sector, is around those integrated community teams working in neighbourhoods. So this isn't about us defining the neighbourhoods as Greenwich and saying, well, you're a neighbourhood, you've got to behave like this. It's about us working with people who will perceive themselves in work in neighbourhoods, and neighbourhoods means different things for different people, but particularly is about the connections between the community and the voluntary sector and the local residents, and about making sure that we build our services in an integrated way around there across health and care. And then the last priority in this area of staying well is really around that whole area of inequity and inequalities, and about trying to reduce those unfair and avoidable differences in health and well-being. And then the last one on age well. And we did sort of consider putting in die well, because actually there's one certainty in life is we will all die. I don't think everyone is always happy with those words. So, but within age well, there are priorities about helping people to age all the way through to the very final days of life and making sure that they're appropriately supported. And so the work we do on carers is included in this, but carers can actually span young carers as well at the start of life. But that's the overall approach that's there. So that's the whole level of the 10 priorities. Underneath that, we've got a clear 5-year vision. It's articulated. So in the document that's in our pack, it articulates what are those outcomes we want to achieve over those 5 years. And then we've got a more detailed plan of what we actually want to do in 23-24. So Daniel circulated the draft version of kind of the designed version. And within that document, that's got a really good delivery plan at the end, sets out what the specifics are. So the questions, for example, from Councillor Morrow and Taggart Ryan around specifics and money, if you looked at, say, family hubs, that's one of the priorities within the children's bit. We've already opened now our first family hub in the Thamesmead area. We've got one out, and we've got 2 more opening up in the autumn. So they are the specific, tangible things where we're putting money and resources against those priorities in our delivery plan to move that forward. So those delivery plans, so the plan for the health and wellbeing strategy is what we would want you to do is to agree the overall 5-year strategy, health and wellbeing strategy, and what we will do is we will update each year that delivery plan of what we're going to do each year against those priorities. But we're not proposing to change the overall framework each year, but we will be updating those specific things against those 5-year outcomes that are set out in the document.
Thank you very much, Steve and Neil. First of all, just before we go to questions, I'll just start by saying it's good to see the principles are set out like that, but the almost alignment with our Greenwich and obviously the ICS strategy. And I guess one thing I would highlight is core to our vision here is about health, is about public health. And actually, if you go into our Greenwich, it talks about our overarching vision being about supporting the health and well-being of our residents. So it's good to see that alignment to our #1 mission. And I guess in looking at the action plan, which we'll go into a bit more, has everyone got a copy of that, by the way? Has everyone seen that in their pack?
It's in the middle.
In the middle, okay. Yeah. Core to that is obviously, you know, as I open for questions, is if we're all sitting in this room talking about this strategy, but actually the implications of the strategy are felt on people, where people live, you know, and obviously if you bring up that slide that talks about feeling well, aging well, and all of those kind of things, you know, it's really the day-to-day lives of people. So I guess the first question for me is going to be how people access services, obviously #1, and accessibility to services in terms of where people go for that support. 2 is obviously about comms and communications, because the success of our health and wellbeing strategy is understanding that our residents have a visibility of what we're trying to do in terms of move people's health along, in terms of increasing life expectancy, and all those data sets which show that actually in terms of the national average we're not performing well on, or if it comes to children and young people regarding weight and healthy eating and all those kind of things. So how do you translate that into that super localism that actually we know that people know where they can go and get support and know what is available, but also who is the messenger? So in terms of who is the messenger, we saw during the pandemic we were using different communities to be the messengers of other communities. We were seeing neighbors talking to other neighbors about vaccinations and all that kind of stuff. Who are going to be the neighbors and the messengers that help carry the priorities of the Live Well Greenwich priorities? Thank you.
Thank you very much for your question. So I think the exciting thing where we've got is in terms of once we formally agree this is our document to formally kind of engage and work on. This is the work that, in terms of how this has been developed, is through the Healthy Greenwich Partnership, which essentially reports into this, and it's a shame that our chair, Nayan Patel's unable to be here today. But it's basically through that partnership, which has got all of the community and voluntary sector represented, with Healthwatch, with all of our partners, is where we've been doing the detailed work. I guess the key opportunity now is to get out and to activate the work. So we've been really clear that, you know, some people might want to come and stream online to see a health and wellbeing board in existence, but we're not. I've got a huge audience behind me. That's not how we're expecting to. What we're expecting is to go out there. So Steve and I, for example, a few weeks ago went to Thamesmead and we did a presentation all around physical activity and got people. We had over 40 people participate. A number of people, I think 26 people, were physically there, and then we had a number of people who joined online as well. And we've been going out and about the community against these priorities, getting their views. What do we need to do? And what was fascinating, and without trying to sort of go into the next agenda item into too much detail, but it was people saying, well, physical activity for us means this, but this is the barrier, but these are the opportunities. And the examples were, you know, they were highlighting that in this local mosque that there were some men's activities that were going on but there were less activities for the women. But what could we do? And you could say, well, what you need to do is just improve the access to gyms or something like that. But actually, an even better way would be to bring the physical activity into the mosque in a culturally appropriate way that feels safe to the people there, that's maybe led by someone who is part of the mosque and champions it. So it's just like you try and change things and get people involved. And what was lovely is then the conversations you have in the room is you got 4 or 5 different people who've got the skills. There was Greenwich Dance Agency and others there who've got the skills to train people up. And actually we've got resources to put in to help make that happen. And so suddenly you go from a kind of a challenging conversation to how do we enable this, and people in the room saying, well, I can offer this, I can do this. And we've had another example when we're in an event around cardiovascular disease in Eltham, and there was a lady saying, well, I love to cycle, but I can't because my knees, and she was in her 70s, and the guy from Greenwich Cycling was there, and he's amazing. So they said, well, we've got these hand bikes. We've actually got bikes where you can have 2 people on the same bike together. So come. And she was like, that'd be great. I'd love to do that. So you're suddenly realizing that this isn't about us necessarily doing to people. It's about people sharing and ideas and facilitating that work. So I'm hoping that there will be formal routes, things like the Multi-Faith Forum that's now getting up and running. I met with them. The role with the community and voluntary sector. I think we've got a massive opportunity with something called the NHS Greenwich Charitable Funds. So we've just got an organisation who will help us distribute those called Groundwork London, and we'll be giving away about £1 million a year. And the framing will be about the health and wellbeing strategy. So providing we approve it, that will be £1 million a year that will support low grassroots organisations. So in terms of getting the message out there, that is going to really connect with people, because money kind of helps in that. And I think this will be about, the key will be making it real and activate and getting people to champion. But we've got a lot of great stuff to build on. We've got our kind of Greenwich community champions. I'm hoping that most of you already are community champions. I am. And it's about those networks that bring people together. So I'm really excited that we can move things forward.
Thank you very much. And obviously that's talks about work on the ground and the messenger. In looking at the 1-year strategy, really bold activities that you set out there. I guess the next question for me would also be how you relate with other services. So, for instance, for example, you talk about school play streets and school streets and all that kind of stuff. Talk about open space and activity. In some of these things, for instance, smoking is quite one that you run your programs on, but where you don't have the levers to move much things in terms of building and accessibility to open space, we know that there's an inequality, a hidden inequality that exists with regards to accessibility to open space and play areas. With such activities that you propose, how do you intend to work across with other departments, say, for instance, regeneration and development and other areas, to help achieve the high-level objectives that you've set out in the plan? Because obviously that's going to be very relevant and key, number one, but also noting to be able to do that kind of work, you also need to know where the gaps lies. So who's doing that kind of cross-cutting work of understanding where there is a lack of accessibility to different services? Thank you.
Could I say one thing, and then I'll bring Steve in? So I think part of having this formally approved by the Health and Wellbeing Board, and the fact that it is part of the Greenwich strategy, gives legitimacy across all aspects of the council's infrastructure to say this is something that they are by default part of. So I think that would be my first point to say, rather than just saying, oh, a little bit of the NHS came up with an idea and you can kind of quietly ignore it because it's not a key priority. So I think that does actually give some criticality, and maybe I'll just ask Steve to then unpack.
So I think we've probably got a bit of a mixed picture at the moment with some of these things. We've already got very good partnership working involving cross-departmental colleagues. And in others, maybe not so much. And that's partly why we've also asked the board to sort of ask the Healthy Greenwich Partnership to do a piece of work to check that we've got the right delivery mechanisms in place and the right players are engaged. Because you're absolutely right, Chair. the insights that you get when you speak to people in their places, in their communities, the event that Neil mentioned, the group that I was in, there was a lady there saying, you know, I'd love to use this fantastic park that's on my doorstep, but I don't want to go in there on my own, even in the daytime, because I don't feel safe. Now, that's not right, and that's the sort of insight that we need to hear from people. And we need to be able to be taking it to the right colleagues that might be able to have the levers to help to address that. So yeah, I think that's absolutely critical.
Thank you very much. We'll go to other questions. Can I just hands for indicators? Okay, Rachel, and then I'm going to bring in Joy, and then I'm going to bring in Matt.
Can I come in particularly on this point, because my questions were sort of in the same ballpark, but particularly looking at the work that digital cities are doing with housing department, who are specifically looking at the neighbourhood element of the housing department, and having, you know, looked at some of the data which isn't out yet, but I happen to know from my particular ward, the neighbourhoods come up as the most deprived by significant, about 10 percentage points more deprived across each of their criteria. So our question is, have you been working particularly looking with digital cities at that data set which is coming out? And how are you breaking that down to sort of the hyper-local? So, for example, for my ward, how would you be looking at just Horn Park being one particular area where actually health outcomes are so determined by the built environment, as well as employment prospects, and the various indices of poverty are one of the biggest outliers. So how are you breaking it down, or planning to break it down into that kind of hyper-local? But then also within that, I didn't see in your presentations exactly where isolation and loneliness fits in as a preventative. So I was quite interested to see where you're envisioning action on the health incomes of that. And can I just add one more? It's about particularly trust building with particular communities which are not traditionally had a lot of engagement. I'm thinking particularly our traveller community and some of our communities, such as Nepalese community, which not necessarily have English as a language. So are you looking at particularly difficult groups that have not been engaged with this kind of intervention before? So that's my 3. Thank you.
So if I start, so yes, we are using hyperlocal information. I'm not particularly personally familiar with all the details from the Digital Cities report, so I haven't seen the report you're referring to, but I know the team have got access to that data. And what's interesting in terms of Horn Park, there's a whole neighbourhood approach. So when I was talking about the neighbourhood development, there's a particular piece of work about engaging and working with the Horn Park community, which isn't just about the physical, but it's about all the other aspects and bringing that together. In terms of loneliness, what was really interesting is there was a small grants programme that we ran last year that was kind of co-funded from Greenwich charitable funds and the council funds back in sort of 22-20, ended in sort of March 23, and we had an event recently. And one of the things we asked for is what are the things that communities are struggling with, what are the bits of feedback, and what were the kind of services. I think there were 75 different grants that were made last year, and loneliness was the number one theme that came out of that. But what was interesting is one of the number one themes of the people who were recipients of the grants was their inclusion. So when you're providing services to people, it's often about the connections and people starting to feel they've got agency, and then that really improves their mental health and their health and well-being. And that, so they turn from being kind of disempowered into people who are empowered, which in itself creates a big difference. And that actually starts to really build that trust. So I think it's about trying to kind of keep the momentum on that work. And in terms of Nepalese, there is specific work going on. So Dr. Anish Chasarati, from local GP practices, has been going into the mosque or the temple, and They started that work during the vaccination period with COVID, but they've carried on following up with that. They've got a number of people who speak Nepalese as a practice. They've done outreach. They've then identified health checks, then number of people who hadn't been registered with a GP, they're now registered, identifying people's blood pressures, etc., and making sure people are on the right medication. So there's some really targeted work, but it's done at a very kind of hyper-local level, which is kind of what you need. And it's important for us to be able to sort of demonstrate the reality of that at an aggregated level too. And I think that's part of the focus of us having not only the formal health and wellbeing boards, but where we have the informal ones where we can go into the local communities and actually see the work on the grounds which we've done recently.
If I could just add on to that. So you mentioned earlier about some of the ways that we worked differently during the pandemic, and that's part of the thrust of the health and wellbeing strategy, to sort of bottle some of those different ways that we worked with our populations and make sure that we use similar approaches for some of the knottier and more sort of inequity type issues. And I think one of the things that needs to look like is insight work with some of the communities where we haven't necessarily been as closely aligned, so like the traveller community, as you mentioned, getting alongside different sectors of the community, as we did through COVID with those where the risks seem to be highest. We need to apply that same kind of methodology to the implementation of our strategies and try and make sure we are talking to, hearing from and working in partnership with those communities where maybe we haven't been as closely associated before. Just specifically on the Horn Park, Neil's mentioned that there's actually quite an exciting programme of work that is happening that you probably have some visibility on, but maybe we need to kind of bring you in a bit more, Councillor. And it does involve our community champions, the public health team. It involves Digital Cities, the housing department, and looking at the assets of Horn Park. I know there's, as you say, there are real kind of challenges there, but there are assets and opportunities, and it's one of the areas that we're looking at focusing on as a key geographical patch for the next period of time, with the kind of new thinking around the neighbourhoods approach.
Thank you very much. Other questions? Joy, and then Naomi.
I think it's a fantastic strategy. It certainly has my support. But one of the questions I've got, on page 61, you have some reflections on the last health and wellbeing strategy, and essentially it sets out that it was more or less sort of scuppered by the pandemic. So I suppose just a query, did it achieve any of the things it set out to do, the last strategy? And the other reflection is that I'm assuming that from the first ever health and wellbeing strategy, the ambitions have always been to increase life expectancy and reduce morbidity, so people have more years in better health. I'm assuming it's probably always had an intention to reduce health inequalities. Are we moving in the right direction, given that there have been health and wellbeing strategies for many years now? Are we actually moving in the right direction? Are health inequalities, have they reduced in the last decade? Has life expectancy increased in Greenwich in the last decade? Has morbidity got better in the last decade? Because, I'm sure you must have been doing this for at least a decade, probably more.
So I think you're right. You need to look at some of those big ticket health outcomes over a much longer time period than just a year or two. And if you do look back historically, you can see really significant shifts and changes in health outcomes from things like heart disease, for example. And we know that those are to do with significant advances in treatment, but they're also to do with major changes in policy at both kind of national and local level around things like smoking, the smoke-free legislation, those things you can actually see when you look at trends in things like heart disease, lung cancer over time. You can see the impact of policy on the numbers. It doesn't answer your question about the last health and wellbeing strategy and whether we have achieved the things that we set out to achieve. I would say we probably hadn't got to the point where we'd got the same kind of list of actions that we've got in here for this strategy to be able to kind of mark our homework against. And indeed, because of the impact of the pandemic, some of the things that we would have been wanting to see move in a particular direction actually moved in the wrong direction. So childhood obesity, for example, we saw a huge step up in the first year of the pandemic in our National Child Measurement Programme. And that was national, that was London, that was local. And unfortunately, what we also saw was not only a significant increase in rates of overweight and obesity, but we saw the biggest increase in those being amongst the most deprived children and a much smaller increase amongst the better off children. So inequalities absolutely widened during that time period, making the task an even bigger one. And in part that may have corrected itself because those were artificial times and unusual behaviours and circumstances, but it certainly didn't help.
Thank you. Any other questions? Naomi, I think you were going to come in, then I'm going to bring in Matt, then I'll go back to Rachel.
Just thought I'd do my bit on the voluntary and community sector now, and maybe there might be one little bit of a question. So looking at the delivery plan, there's loads in there that relates to the voluntary and community sector, which is absolutely fantastic. And, you know, I think there's been a huge sea change within the borough in the past 3 to 5 years about a recognition that actually if the voluntary and community sector are supported, they can really, really help the whole system, and it's a relatively cheap way of doing it as well. I think the only thing that, and I think the other thing is public health, really you learnt through the pandemic around how to get money out to the sector in a different way than your traditional kind of grant process, which is also fantastic. My main concern is actually developing a base within the sector. So giving lots of small grants out for specific types of service is great. But actually what we need to do, and I think we have issues within Metro Gas because we were cut during the last process, is build the base of the sector so that it has a solid base to continue to deliver and isn't totally dependent on the odd small grants process that appears every so often. And I think that's the only thing that may not be totally there at the moment in terms of the strategy, but otherwise I really commend it.
Thank you. Just before I bring in Matt and Rachel, can I ask, and before you go to a response, if we agree this today, it goes out for consultation, right? There's no consultation whatsoever.
So our view, and this is what we talked through in the December meeting, because the Greenwich, in terms of the priorities, have already gone through that. So in terms of the 10 strategic priorities, they have come from the South East London's work, which was all developed with people and integration with many, many different events, and then the priorities that came out of Greenwich, which obviously involved loads of public engagement already. So the proposal around the 10 priorities, we're not proposing to go out and say, okay, you know, what we want to do on the engagement side is how to actually make these things real for you in your community and involve people in that. So that's where we want to put our real focus on the comms and engagement.
Okay, thank you. Sorry, I'll let you get back to Naomi.
And then, Naomi, I think your point is well made. I think, you know, the community and voluntary sector have a huge opportunity and a critical role. And I think the participatory grant process, the thing you were kind of referring to, is exactly the kind of models we want to move to. I do think we need to say, what is the best way to support the sector as a whole? What are the opportunities for doing that? And I think, you know, that's something that obviously the council have a particular role in kind of providing those funds. But I think across the health and social care system, we need the sector to be robust, but we also need it to support every part of the community and voluntary sector system, and that's something that's kind of got to be an ongoing conversation about what's the best way to do that and evolve it going forward. And I think the work that Tal's doing from a South East London perspective, and the Charter is part of how do we do that. And it is a very diverse sector as well, isn't it? And it's what's the best way to do that? And I think that's got to be an ongoing conversation. But a legacy really for us should be a really thriving infrastructure for it, as well as the individual organisations as well.
Thank you, Matt, and then Rachel.
Thank you. I wonder if we could have the slide back up that has the two graphs, one mortality and then the other morbidity. Is that, I don't know who's doing that. Daniel, thank you. So I've asked similar questions before, but that I don't disagree with what's being said here, but I don't see any plan to change what the NHS is doing to focus on people's experience of ill health. So that traditionally we spend more on things that happen to people in the last couple of years of their life, and we spend more on physical health than mental health. And these stats would seem to be an indication that we will carry on doing that. So cause of death, heart disease huge, cancer huge, lung disease huge, but then the experience, I'm interpreting morbidity as the things that make us ill generally. That might not be the right thing, but so we've got mental health is much larger on there. Deaths from suicide are not recorded except under deaths by injury. I think they should be recorded as under mental health. So the things written in the plans are all right again, but there's no measure of what we're doing to respond to this and how we're changing what we're doing. So we could have this report and make some really amazing, great changes that really impact on people's lives, or we could have this report and make absolutely no changes. And in both cases, we'd have lived up to what's in the report, because it doesn't explicitly say that we're going to change anything.
So my challenge back is actually, this just tells you the figures. We are doing a lot, and that's what's set out in the delivery plan. So if we go on to maybe if we go into the detail of the plan, and maybe the version, the nice designed version there.
So is
Hold on, wait, so I'll just let you finish.
So in the delivery plan, we set out the 5-year outcomes of what we're trying to achieve on mental health, both for children's mental health and adult mental health, with specific outcomes of what we're trying to achieve through that. And then our delivery plan, and you'll be familiar for the child and adolescent mental health delivery plan. So if you've got the 39-page document, which sets out the delivery plan under Feel Well, the specifics on children's mental health is the Thrive implementation. So the setting up of the community, the adult side, do the children's side first. So the I Thrive approach for preventative approach for children's mental health with a single point of access in the schools offer. That work is being put together this year. That will improve the knowledge and understanding of practitioners and schools on supporting children's mental health and wellbeing, creating that single point of access, improved triage, referral processes, and so people get more timely access. We're setting up a new integrated clinical health team within Royal Borough of Greenwich's Children's Services, so we've got Oxy staff working in a much more integrated way that supports all of our social work teams, so that we'll be able to make sure that we get better early intervention for children and young people, preventing that escalation to specialist mental health provision. And then there's a specific piece of work we're doing around reducing waiting times for specialist child and adolescent mental health services, and we've put in additional funding to support that. So they're sort of 3 examples of the specific details that are in those delivery plans associated with it. So I've just chosen the children's one as an example, but that is true throughout all of the 10 priorities. There are specific details of what we're going to do this year and resources against it. I think the slide that is called out here is what's mental health is, you don't die generally of mental health unless it's suicide, but you do. There is a big psychosomatic and impact psychologically of all of those other physical health issues. So the mental health support is absolutely critical. So we've got, for an adult side, we've got online support that's been put in there. There's talking therapies support that's there, as well as more wider intervention. But we know that active engagement with people is so critical for their health and well-being, and that's why the work with our communities is so critical. And the point that Councillor Ryan highlighted around loneliness, it's about connecting people. So one of the informal health and wellbeing boards we had in the kind of Blackheath Charlton area, there was an example given where someone had recently been bereaved, and someone was they were very down, they were on their own at the home, and then they got involved in the Charlton activity sessions and went along with someone, made friendships, and their whole life kind of outlook turned around. Yes, they were still widowed, but they'd actually made fresh connections and fresh relationships, and that was someone talking about that example. So there's quite a lot that we need to do in that community engagement side as well. So all of those aspects are part of our work, and so the delivery plan is the detail. I guess this is the picture of where that burden and those percentages are, and I guess to join up with the earlier conversation, it's about the investment. So nationally, there's a commitment to something called the Mental Health Investment Standard, which is actually saying that's proportionate additional in all new money that comes in to the NHS, more money always goes into mental health. And that's been particularly put into more in terms of the prevention and support places. So we've got a whole range of initiatives. Is there more we need to do? Yes, there is. We're not complacent at all, but there's a lot we are doing, and there is additional investment that's going in.
Thank you. Just before I go back to Matt, I'm going to bring Florence in because I know there's a relevant point that she wants to go into. Mike.
Apologies, about prevention work, and that prevention work that impacts on adult health cuts across such a huge range of work, whether that be prevention work in schools or in health or in crime reduction, and they all come together and lead to, which is why it's so important to have a really system-wide approach to prevention, and indeed to longer-term sort of causes of ill health in adulthood and death. Perhaps there are sort of in the future, I think this plan is now done, but maybe there are other ones about sort of the quality of life, because it isn't just about morbidity and mortality, but the quality of life.
Just to comment on that, I mean, I think we would see this health and wellbeing strategy sitting within that wider programme of our Greenwich and all of the other things that we've got, the other missions in there that are trying to create a fairer, safer, healthier, wealthier population for Greenwich, because all of those things contribute probably more so than NHS services to people's mental well-being as well as their physical health and well-being. So this is an important part of the overall programme, but I think it sits within the wider framework.
Thank you. Matt, did you want to come back in? I know you had a comment before I go to Rachel.
Examples of things that are being done could exist in a system where the proportion of spending on mental health is still going down. There would still be examples that we could point to of things being done. It could also exist in a system in which the proportion being spent on mental health is going up. Examples don't tell us whether or not it's going up or down. There's no measure in this report of preventative versus spending that responds to people being ill versus spending that works on people's health generally. There's no information in the report on the proportion of spending for mental versus physical. There's no information on the proportion that's invested for somebody living with a long-term illness versus dying from a very serious illness at the end of their life. So there's just no attempt to get to grip with the actual spending and how it relates to people's lives. So, as I said last year and the year before, all the right things are being said, but the actual change hasn't happened, and there's no reason to think that it will. So
just on that, then, Matt, is your recommendation to say you want to see the budget behind these proposals, or the financial investments and where they're going? Is that your recommendation?
Yes, but specifically we need to see the whole of the spend, the whole of the NHS spend, and the proportion that goes into preventative year by year, and the proportion that goes into mental versus physical year by year.
Thank you very much. I'm going to bring in Rachel now for her question, and we'll go back to that recommendation.
Well, maybe that's covered, because my question was, I don't see the spending commitments in this, and whatever happens at the next general election, the next government is not going to be bringing new money into the NHS. So how much of this is being met within existing budgets, and what is dependent on new money coming in?
So just before you guys go to answer, obviously we're here in principle to agree the draft health and wellbeing strategy #1 and the action plan, which is key. So what might be worth doing is we bring back another item at another health and wellbeing that focuses on and drills down into spend, more importantly, which I think alludes to both of your points, to go back, because I think we're all on the same page in terms of saying the right things and other additional things. But there is a point into drilling down into how the action plan is actually resourced and financed. There's another point about NHS spend, which I think is a really important point to labour. And actually how, and Neil, I guess there is the demonstration for you about where the NHS is at with their spending and their commitments. Obviously, we don't have any authority to determine how much your spend goes which way or the other, but ultimately we do have the authority to be able to say we want to see the spend and understand how it relates to the activities, but also how it aligns with our own spend as well. Because obviously this is about a collective partnership, and it requires all of us putting some funding on the table to be able to initiate and deliver on these priorities. Sarah, I'll bring you in now.
Yeah, I think we can certainly look at bringing something back that helps to set out the spend in the totality and some of the different layers of that. It's important, I think, to just recognise that NHS spending is mostly driven by national decision making. So the mental health investment standard is something that we have to meet as a result of national requirements, which does put more money into mental health. But there will be other requirements that central government have, for example, around waiting lists, which will direct money in certain directions. So that's, I guess, just reiterating your point really about how NHS money overall is spent. I think the next thing just to recognise is that, as we referred to earlier in terms of the integrated care system strategy, the Integrated Care Partnership has agreed a medium-term financial strategy which over 5 years shifts money from the acute spend into prevention and early intervention. So that's the 4 million it starts off as, but that pot grows over the 5 years, and that money will be allocated to those 5 priorities. So that's where there's the sort of some scope, if you like, in terms of the integrated care system, the partnership that includes all of the boroughs to direct some of that money. And then, as the leaders just set out, we have the money that the borough puts in as well and how we direct that. So I think it's just to set out those different levels and where there's scope to influence that.
Thank you.
We can
Naomi?
certainly bring something back.
I'll try to be quick. Some of it is how the money's spent rather than how much it is, because the NHS has a lot of money, but we still have, stats that aren't great. So to me, it's probably about how we look at this in the long run and whether we come with each priority and say, this is the amount of money being spent and this is the impact I know it'll take time for some of these things, but, the work that's already happening around blood pressure and things like that, so we can start to demonstrate that the money is being well spent, or actually we need to think about where the money's being spent because it's not working. So I think it's maybe how we report back to demonstrate the impact of the money over the next 5 years.
Do you have a recommendation there?
Okay, recommendation that there are regular reports back on the priorities indicating spend and developing impact. Is that okay?
Thank you. Matt, I saw your hand up.
Thank you. Yes, I'm aware that the national structure affects what's happening here in health service as it does in a lot of areas. So I'm certainly not trying to hold local organisations accountable for things they've been directed to do nationally, but that doesn't prevent us from producing meaningful statistics. So with mental health spend, there was a long period of about 10 years where people talked about, first they talked about equality of esteem, and then they talked about, you know, equality of funding, and during that period, the actual funding as a proportion of the whole went down and down and down. And in the end, they've made a national directive in an attempt to reverse that. So, you know, there's nothing to prevent us from accurately describing what's happening. And that's what I'm asking for, because if this 4 million tranche is the first of a general change in how spending is done, then that's great. But it may or may not be, and the report would be the same, whichever is the case.
It's also sorry, just say it's also tiny. You know, just to recognise that in terms of that overall spend. The other thing is, you know, the investment in mental health might have gone up, but so has the demand. So yeah, it doesn't necessarily feel like there's more money going in.
All right, so I think that brings us to a conclusion on that particular debate. So just by way of the report, we will agree it, number one. I guess with the caveat, though, that I think there is a view to understand how the resourcing is dealt with in the action plan. And I hear the point about I hear the point about consultation, noting that you've had the ICS engagement, noting that you've had Greenwich. I do think there is a different conversation that's had when it comes to the health and wellbeing strategy, and the very act of having a consultation helps to engage minds. But actually, I think to the point that you made is actually there needs to be a conversation around the action plan, really. So what I would like to see, and hopefully collective agreement here today, is how you action conversations around the action plan and feed on to the point that Naomi talks about. It's about the how. So obviously you've got the finances, great. Yeah, you got some money in there, fantastic. But how are you using that money to make sure you deliver on the outcomes? Are we doing the right things by way of commissioning and all other things? The established things that we've been doing, are they working and all that kind of stuff? So are we happy to agree the plan? Yeah, okay. Second of all, I guess you'll come back here to talk about the how and the finances, which will be helpful for all of us understanding that, but encourage more conversation around the action plan with what I would say is the service user as well. Thank you.
Thank you. Thanks. It's been really helpful conversation and really found it beneficial. Thank you.
Right. We'll now move on to item 8, which is the Getting Greenwich Active, the annual report from the Director of Public Health. So I'll hand over straight to Steve for a whistle-stop tour.
Thank you, Chair. Yes, it will have to be that because we've got 3 items left and half an hour. So can I invite my colleague Jane? Oh, she's over there. Jane Connor has been very involved in drafting this report. So we're going to do a quick presentation and probably won't have time for too much discussion. But I just want to show this video, which just lasts for 2 minutes to begin with, which is a bit of a scene setter.
Thank you. Just on the video, do we have accessibility for members of the public to be able to see this?
They wouldn't be able to see it.
Okay. So can I just ask, for the sake of the minutes, that we include a link to this in the appendix when this is published to the website, because obviously I'm just conscious that we've had many presentations here which members of the public might not have accessibility to. So Daniel, if you just note that for the sake of the minutes, for all items that have been presented to be added to the appendix, and I'll let you go forward with shooting the video. Thank you.
Thank you. Those are some big numbers for those different conditions that American public health professor talks through, and it's worth watching the rest of the video. It's only 10 minutes if you have time, because he talks you through some of the robustness of the studies that led to that data. And his proposition is basically, if we can limit ourselves to sitting, sleeping, and resting to 23.5 hours a day, then that's the biggest benefit that we can have to our health and well-being, mental and physical health and well-being. A few years ago, just before the pandemic, the 4 chief medical officers for the UK wrote a joint report on physical activity, and in it they said if physical activity were a drug, we'd refer to it as a miracle cure due to the great many illnesses it can prevent and help treat. So it's not only a preventative thing, it's also very important part of recuperation for a whole range of different conditions. And on that slide, there are some more numbers that you can see related to different mental and physical health conditions where physical activity is a fantastic prevention and treatment method. Next slide. So in terms of what sort of physical activity we're talking about, as Mike said on the video, we're not talking about triathlons, we're mainly talking about the sorts of things that we could pretty much all build into our daily lives. So moderate physical activity and reducing sedentary behaviour. And we know that moderate intensity burns off 3 to 6 times as much energy, and it's really critical in giving us good cardiovascular fitness. So activities such as brisk walking, stair climbing, housework, gardening, things that get your heart beating a bit faster, raise your temperature, make you breathe a little bit heavier are the kinds of things that we're talking about. So you can do spin classes, you can run marathons, but that's not what we're asking each other and our population to do. That's not where the evidence tells us we need to focus. And it's also really important for people of all shapes and sizes. So there's an awful lot of emphasis on weight, but actually cardiovascular fitness is the most significant predictor of health outcomes. So, even if we are in a category where our BMI says we're overweight or obese, if we are regularly physically active, just half an hour a day, that ameliorates a lot of the risk factors from being overweight or obese, and really kind of corrects some of those risks. Next slide. This slide just shows what we call the dose response. So basically it's saying you get the biggest impact from going from doing nothing to doing a little. And then if you carry on doing more and more and more exercise, the increase in health benefits is marginal. So the biggest impact that we would have on our own and our residents' health is to get people who are inactive to be a little bit more active and then a little bit more active. So the kind of couch to 5K sort of model, which is about incremental increases in people being a bit more active and a bit more active. Next slide. And we know that there are wider benefits from people being more physically active, opportunities for people to get out and meet others. Obviously you can do sport, or you can join walking groups, etc. It has a real benefit on people's ability to learn and concentrate and do well in educational environments. It's really good for mental health as well as physical health. It has a beneficial impact, things like active travel on our carbon neutral strategy and our green plans, etc. Next slide. Is this you, Jane?
Yeah, it is. Thanks. But we can see that the residents in our system faces really significant challenges around physical inactivity. Of course, at least 60,000 adults are sedentary. They're not taking any kind of meaningful activity every week, and only a third of adults are kind of doing enough. And that being sedentary kind of adds significant health risks. So we want everybody to be active, moderately active, a bit more intense, about at least 30 minutes a day. But we also need to understand the kind of benefits of reducing, sitting less basically, and standing and moving more. And obviously societal changes, and COVID's had a particular impact on that, because for a section of the workforce, people are working at home more and are far less active than they probably were. It's really worrying about children, because only half children are doing that hour a day. Schools do a really good job, and there are things that are happening around schools, but we still only got half our children being active for 60 minutes or more a day. And also within different populations, because often there are particular barriers to being active, we've got groups that are less active. So women, young people, some black and otherwise minoritized groups, older people and people with disabilities have lower activity levels than the average for the population. Next slide. But there's a lot going on, okay? And a lot of that stuff is about our environment, the incredible assets actually got. Greenwich has got one of the highest numbers of green flag award parks in the country. We've got really good kind of structured leisure centres. We've got a sort of a reasonable baseline of community activities, and then often accepting it short term, some of the stuff that we've had through things like community innovation grants, community voting days. We've got targeted, particular sort of programmes for older people and so on. And we've got lots of low cost or free activities. But there is, and I think you've touched on this in previous discussions, one of the issues is how do people know what's going on? And actually, I think, so part of it is this report. So the aim of this report is not to tell everybody about what's going on and how you can get active. The aim of this report is actually raising awareness and understanding across the system. So health providers, care providers, everybody around actually knows how important and how beneficial getting more active is. And then we also work with them to kind of help understand how you can kind of share that information. But actually word of mouth is often the best way. And what I think, Anthony, you talked about the hyperlocal. We've given examples. And that's what our residents are telling us. That's what the evidence suggests. And so it's actually about, yes, it's about having things like websites and strategies, but it's actually about working with people at a local level so they both know what's going on, they create what's going on and tell us, okay. And one of the initiatives we've got is physically active primary practices, so that they're actually better done at that. Finally, what do we plan to do next? This is, as I say, this is about raising awareness. It's about it's also the start of engagement around reshaping Greenwich's physical activity and sports strategy. So we had the public forum, we're having discussions like that, and there'll be a plan for engagement with communities, with providers, sort of later on in the year, because we need the new physical activity and sport strategy to actually focus on the things that we can do and the things we can change. I think that reflects some of that earlier activity. Actually, so much of what our health is actually determined, it's determined by government policy, it's determined by things like the commercial determinants of health. So what is it that we can do locally, and particularly what can we do with communities to kind of generate activity? And the final point is I think it's about the other thing that we're doing is again that engagement with providers, with communities, thinking about the actual services that we commission and what do they need to do, as well as the wider picture.
Thank you very much. Questions, just very briefly. Joy?
Yeah, great strategy. A couple of things. One, how's it linking up with employers? Because obviously they have access to people, and obviously getting people up to date and perhaps encouraging staff to be more active. And I suppose the other thing goes back to something that I said to Steve, not to put too fine a point on it. You know, public health has been banging on about this forever, for the last, 20, 30 years, and it's really important. And I think if you stopped 100 people outside the town hall now, I doubt any of them, if you said to them, do you think being active is important? They'd all say yes. So why hasn't it worked before? I mean, I know you know, you don't have a magic wand, but I'd be really interested to know, this has been tried so many times and it just hasn't worked. Thank you.
So,
I mean support of it, by the way.
Jane, you've heard me say this before, but I thought I'd say it to the Health and Wellbeing Partnership as well, which is the previous strategy didn't really target specific groups, and I really hope that the next strategy really does look at targeting people, whether it's around culture or gender or disability, because actually I think that's one of the issues at the moment. We have very generalist services rather than targeting those who are most, have most obstacles in front of them.
thank you. That's a really important point about targeting, but more so services that are really well targeted and are not general. I guess the one point that I'm going to make is I think I was at Together 23 and I hadn't heard the street tag. And if we haven't if councillors haven't heard it in this room, how can we expect our residents to know about it? So I guess the question I have to really prod is the comms and the community engagement around this, because obviously people need to know it. Rachel, coming in for last question.
My question really is about schools and how are we working with schools with us to, particularly in the primary sector, to build in that early habit of exercise. I took PE until I was in A-level, but that was only like 4 of us in a year who did that. And nearly all the other girls in my year dropped out of PE very early on. In this thing it says about standing stations and moving around, but what can we, that seems very minimal in terms of what we can do within schools to be able to encourage a life habit of exercise.
Thank you, Jane. And Jane, can you just, for the sake of the video, introduce yourself and your title, please?
Apologies. I'm Jane Connor. I'm the Acting Assistant Director of Public Health at Greenwich. Just workforce, absolutely agree, Joy. And I think one of the things, we've done some work with Chamber of Commerce and things about various things like food, about alcohol, mental health. And I think getting that awareness for employers about not just about, you know, the importance of it, but I think it's what we're saying in terms of the messaging. So much of it needs to be much tighter, much simpler. Just your 2 or 3 top tips about what you can do, because it can be overwhelming. So I think that's part of the comms thing. Absolutely, I would agree in terms of the physical activity and sports strategy. And I think that's also an element around public health commissioning, is to say that we can never put on programmes at the scale to get everybody active. What we need to do is raise awareness, think about those bigger barriers, so exactly the part that a resident doesn't feel is safe. And we've done some great work, absolutely, around doing that. But then I think we need to think about where the money goes is about, I think you're right, more targeted evidence-based stuff where people face those biggest barriers, and that's right. What's changed? So many things have changed. So many things act against people being active. But I think what we're hearing, absolutely, like a lot of things, is it's about framing it as well about what matters to me. I think we haven't always found the way to frame it so people can see, but it's also somebody, I think it was Shola from Food for Purpose put this out at the public forum. She says, what's my active? Asking people what does it mean for them? What do they want to do, rather than sometimes, I think historically, a sense that we've been kind of saying what you need to do. So this understanding about moderate activity being all sorts of things is, again, that. And I agree then, absolutely, Anthony, the comms. But the comms is about not necessarily the big messaging up there. It's about working with community champions, working with organisations. Again, I think to use the jargon, to actually co-produce some of that framing about what the messages are.
Thank you very much. And we'll go to the next item. Well,
schools is quite a long answer, so I don't know if you want me to start on that or perhaps...
Well, actually, what we can do, we'll take the question through written, and they can formally respond back on that point. Can I just ask for the next steps then? next steps on this?
So this really is a report that's intended to be used as part of the implementation of the health and wellbeing strategy, the Everybody Active strand. So it's a sort of reference report with data and intelligence. So it's not a strategy, but it's there to be kind of a helpful resource for the action plan that we've talked about as part of the health and wellbeing strategy on physical activity.
In terms of that then, can I just ask that it at some point comes back here? Because I think there's still not outstanding questions, but there's still points that need to be addressed in the how and any new initiatives that are going to be undertaken to make sure that we see improvement to Joy's points, which are about actually we've known we need to be doing this for a long time now. Where is that outcome? So can I just ask that it comes back? Probably doesn't need a response, but...
Well, that's what the physical activity and sports strategy will be, and absolutely we'd want that to come back and for you to be all involved in the consultation and engagement on that.
Appreciate it. Thank you. Right, we'll move on to the next item, and we'll go straight to Joy for Health Watch presentation. Brilliant.
Thank you, and I'm going to start with an apology because I'm the only thing standing between you and your lunch now. But I'm wondering, given what Jane said, whether or not we should stand up for 10 minutes, for the last 10 minutes to do this. I think we should. All right, let's stand up. Good. Oh, that's much better.
As chair of the meeting, I just have to say it's... I have to continue chairing.
Oh, okay. All right. Brilliant. Thank you for giving me this opportunity. I will keep to time. Just to start off quickly, just a little bit of background about Health Watch. We're part of a network of 151 local Health Watch. Every local authority in England has to have a Health Watch. Above us sits Health Watch England, but it's not like a McDonald's franchise. It's not a sort of command and control. Each local Health Watch is independent and has its own governance structure and obviously sets its own agenda and priorities depending upon the needs of the local community. Oh, okay. I hadn't finished, but all right. I just took a breath. Essentially, the chair of Health Watch England also sits on the board of the CQC. We feed into Health Watch England, we feed into the Care Quality Commission, and the Care Quality Commission then obviously uses some of that insight and information in their work with the Department of Health and Social Care. I think the biggest difference between obviously local Health Watch and Health Watch England is that Health Watch England's role is to lobby at a national scale for significant change. Sorry, you're trying to focus on me on the camera, otherwise you're only getting my sort of midriff in. Next slide, please. What do we do? Essentially, our role is to hold a mirror up to services. And then we reflect that back to commissioners and providers. So essentially, we talk to people about their experiences with health and care services. We collate that, and we use that to influence and work with commissioners, providers, all sorts of services within the borough, essentially to work towards more equitable services for everyone. Next slide, please. Just a few highlights from our year. I won't go through it in a huge amount of detail, but just to say that lots of people talk to us. A lot of that is where we've done things proactively. So on a weekly basis, we're out 2-3 times a week. Libraries, community centres, voluntary sector groups, coffee mornings. So we're sort of actively out there talking to people. But also people contact us, emails through our website or through any particular sort of campaigns that we're running as well. And we also do deep dives into services. Often those are specific pieces of work that we're asked to undertake by various services, and where we usually do quite a small number of really sort of depth interviews with particular cohorts of residents to find out their experiences. Next slide, please. Is that the next slide? Yeah, it is the next slide. Yeah, okay. So in terms of who we target when we go out and when we try and engage with particular service users, patients, communities, these are the cohorts of people that we are particularly interested in listening to, partly because obviously we know with health inequalities, it's these groups that often don't always necessarily have the best outcomes. So we certainly want to hear as much as we can from those groups. And it's also worth saying that we have at any one time between 20 and 30 volunteers. Most of them are Greenwich residents, and they come from very diverse backgrounds as well. And our volunteers absolutely do reflect the diversity of the borough. Next slide, please. This is just an example of some of the work that we've done recently. One of the reasons why I've chosen to share this one is obviously firstly around the impact. And what was quite interesting about this is that actually all the things that will make a difference are not things that were actually within the remit of the organisation that offered contraceptive advice, because what we were saying is actually if you want to get some real change, you need to work with schools. So again, this is something about this sort of whole system working and how sometimes the system doesn't really work together very well and doesn't necessarily coordinate itself very well. The next one, our feedback reports. I'm sure some of you are familiar with our monthly feedback reports. So each month, we sort of compile a summary of anything between 100, 150, sometimes more than 300 comments, things we've heard, things we've seen about services, and we sort of compile that into the sort of top 10 or things that we're hearing most frequently, I suppose, is probably the best way to say it. Probably about 70-75% of what we hear is about primary care, which is not surprising because, you know, primary care is the front door to the NHS. So we hear a lot about challenges with primary care. And just as an aside, we're still seeing challenges with regards to online registrations. Not everybody has access, you know, to digital tools. We're also seeing online registrations essentially saying people have to have an email address. Again, not everyone has an email address. We're also seeing many GP practices saying people must have ID to register. And of course, we know that that's not a requirement unless you want to use online services. So we are continuing to highlight these things. But I think probably what we've heard is more useful to our health and care partners is our case studies. So each month we feature case studies which really show a person's journey or where they've had barriers or challenges and the impact for them, the outcome for them. You know, everyone absolutely across services are trying to do their absolutely, you know, best job, and I'm sure they are, but sometimes for all sorts of reasons it doesn't really work. Okay, next slide. I won't cover that because okay, this is a really positive case study, so I wanted to put that in. So this was a really nice example of the sort of service I think most of us have most of the time. I think the thing to bear in mind is, I'm sure for 99.9% of people, for 99.9% of the time, it's like this. It's fantastic. You know, it does what it says on the tin. You go, you get seen, you get sorted, everyone's lovely, everyone's fantastic, and that's brilliant. But of course, people don't come to us when things are going well. People come to us when things are not going well. So please don't think that our feedback is somehow representative. It's not, and it never will be. I'm running out of time. I've got 2 minutes left. Well, last year we actually did 21 visits of the 11 care homes in Greenwich, and we tend to do more interim views next year, or this year. Next slide. Just in terms of our priorities, again, because of most of what we hear is around primary care, we'll certainly be doing more work on primary care, but we want to include community pharmacy, dentistry and ophthalmology because we feel that there might be opportunities with that now coming under the aegis of the ICB. We're certainly going to do more interim views into a wider range of care homes, and we're going into QE as well, and we've been talking to them and they've been absolutely great in terms of thinking through with us how we might approach that. Essentially we want to even work again, closely as we do with our health and care partners in terms of the prevention and promoting good health and improving the early detection and management, particularly of cancer and heart disease. Thank you.
Thanks very much. I appreciate this presentation. Can we all sit down now? Just for the sake of the cameras, I was conscious that people might not be able to see us. So first of all, thanks for the presentation. And one thing I'll really say is that, the other day I was actually reading the Health Watch report, which was really helpful and went into really great detail about some of the issues in that particular area of the report that I read. So I just want to thank you for your work, because obviously it's vital in making sure services deliver for residents, and you guys are another eye to that. Is there any questions? Just raise hands of any questions. If not, because of time, first of all, I'm going to say we'll defer the last item to the next meeting.
I was just going to give a comment, which is just that Joy came to the Healthy Greenwich Partnership and went through with a bit more detail this report, and it was really well received.
Thank you. So I just want to say I'm going to defer the last item, which is about the feedback, to the next meeting, which we can undertake at that point of time, just because of time. One question to you, Joy, is about the point of how we further utilise the work you do and align it to what's going on with the NHS and the council in terms of learnings, because obviously one of the things you mentioned is situations whereby people come to you when things are going wrong. What further actions do you think we need to do to strengthen our response to deliver for residents when it comes to holding organisations to account or no longer working with them? Thank you.
Well, I mean, both Naomi and I, we sit on similar sorts of health and care boards and committees, and very often I think we're a bit of sort of a tag team in terms of holding the system to account. And there certainly has been a shift in terms of, as Steve was mentioning, in terms of actually going out and engaging with people more. And I think the more that happens, then local people will hold the system to account more and more. But there's certainly, a widespread recognition and a desire to hear the stories that we're sharing and to take action, on the basis of those stories. But I think it is fair to say that, the NHS, the health and care system, is a huge monolith. And sometimes it takes a long time to see sort of impact and changes. But I feel there's an absolute commitment, across the board, from top to bottom, to ensure that services are moving in the right direction and they're becoming more and more equitable for all.
Thanks very much. I appreciate your presentation, and encourage everyone to keep reading the annual report as well and continue that partnership working. Right, first of all, thank you everyone for coming to the meeting today and participating, and all speakers. Like I said, we'll take the feedback on the next item at the next meeting, because I think that's one that we can actually bring back at some point, and we'll call the meeting to a close. Thank you.